Okay, so developing community services for self-harm. So what I'll do over the next kind of 35, 40 minutes is just do these 5 things, give you a little bit of context around self-harm, kind of current importance, the kind of current policy context and which way we're going. Then a little bit about the current NHS England programme, because there's been a bit of confusion about where the self-harm work actually sits. So hopefully I can give you a better idea of that. Thinking then about the different settings in which we might improve services, improve our offer for people who self-harm, so different care settings. A little bit then about the research evidence. What does the research evidence tell us about the most important components of care after self-harm? And then just very briefly thinking a bit about what the last kind of 2.5 years have meant for self-harm care and what it might mean going forward. Okay, so I'll cover those 5 things, and there'll be plenty of time for questions, hopefully in the discussion section towards the end of this session. So I'll just kind of rattle through these slides really. So a little bit of context. I quite like to start with this one because it gives a bit of kind of historical context really. So I started work in self-harm, suicidal behaviour about 25 years ago, and when I started, this man here was my boss, Alan House. He's professor of liaison psychiatry in Leeds, now retired. So I started off in Leeds, and back then, services for self-harm I think really were quite poor. They were quite patchy. My own view is over the last kind of 2 decades plus, we've made quite a lot of kind of progress. Alan still thinks they're not very good. I think they're a little bit better. These are kind of paired editorials in last year's British Journal of Psychiatry, worth a read, and you can kind of make up your own mind. But for me, there has been progress in the last 25 years, but I think there's still quite a long way to go. And self-harm's got a kind of profile that I couldn't have imagined 2 decades ago. It's mentioned, lots of reports from the Royal College of Psychiatrists, from Parliament, NICE. We'll come on to the NICE guidelines for self-harm in a bit. So it's never had a higher profile, if you like, and from that point of view, we've never had a kind of better opportunity to improve services for people who self-harm. Now, when I talk about self-harm, I'm using, if you like, the broad NICE definition. So it's not just, sometimes when we talk about self-harm, people think we're talking just about maybe non-suicidal self-injury. We're actually talking about self-harm in all its forms, so self-injury or self-poisoning, irrespective of apparent motivation or medical seriousness. Sometimes, colleagues will say, well, surely we need to be separating people out into people who've made suicide attempts, people who are engaging in non-suicidal self-injury. I think our point and NICE's point is that it's not always very easy to distinguish between those groups, and labeling a group non-suicidal, when you follow that group up, we know they're at greater risk of suicide and other adverse outcomes. So we have this kind of broad capture kind of definition, really to make sure that we're not excluding people. That's not to say management's going to be the same, care is going to be the same for every single person. It's really to make sure that it's an important problem and we don't exclude any groups. And it's a big problem as well. So just in terms of hospital attendances, over 200,000 attendances at hospital every year in England. And that's just people attending hospital. So obviously there's all the people that don't, 150,000 people. So it's a big problem, but obviously, one of the things we're really worried about in terms of self-harm is the association with suicide risk. So this is a fairly recent paper, looks at self-harm in older adults. And that's actually also a reminder that, sometimes you talk about self-harm, people immediately think about young people, kids, adolescents, but actually self-harm occurs across the age span. So it occurs in midlife and also occurs in older adults too. We've had a colleague join us, which is great. I'll just carry on. So I think important to remember that self-harm occurs across the lifespan. important also, really important, this link with suicide. So particularly so in older adults, but across the age span, self-harm is associated with a higher risk of suicide. So in this study of older people, 145 times greater risk of suicide. But only a minority, even in this older age group, referred to mental health services. And it can occur at any stage across the lifespan. But we know the antecedents vary. So in young people, often interpersonal problems, relationship problems, educational pressures. In older adults, tends to be psychiatric disorder, physical illness, bereavement, and social isolation. So the targets for intervention are going to be different, but can occur across the age span, and it's associated with suicide regardless. So I've told you already, big problem, big public health problem, major link with suicide. How do we do in terms of managing it? How do we do in terms of existing services? I think this report from Samaritans a couple of years ago kind of summarised the current state of services really well. So it was called From Pillar to Post. And I think, that's it. That's the experience of some people who self-harm, that, they experience very fragmented services. So they might get, see their GP, they might get referred into community mental health team, sometimes bounced around the system, not finding consistent high quality care. Obviously, sometimes in some areas, there's great services, there's great care, but in general, the care is not as brilliant as we would like it to be, and hasn't been historically. And that's really where the current programme comes in. So it's not a kind of standalone programme, this kind of self-harm work, and people often ask me, well, where's the funding from this coming from? Where does it sit? It's actually sitting within the community transformation work. So all of you will have heard of the NHS long-term plan, the blueprint for services going forward. Within that, there's a really important section on community mental health services, and also kind of suicide prevention. But basically, the idea is, quite a lot of funding going into mental health services generally under community transformation work. So it's money for community services, and the self-harm support is one part of that. So there isn't, in answer to some colleagues' questions, there isn't, if you like, dedicated extra money for this. But basically, the expectation from NHS England and colleagues is that this sits within your community transformation work. So in terms of who you link with, some of you, I think, will be very involved in the transformation work in terms of community services. For others, it's about linking in with those people, because, if you like, the resource comes from the wider programme. And the aim really for this specific bit is to help you in any way we can to develop plans to improve community services for self-harm in your areas. So our role is really a kind of supportive role to help you think about what you do locally. Primarily, we're a research unit, but we like to get our research into practice. So supporting you with the evidence for what works and what doesn't. Comment on your plans. So once you've decided on what you're going to do in your areas, very, very happy to comment on those, and particularly thinking about how you implement things. So how you implement things is really important. So we can just try and kind of implement things, but other areas of use, quality improvement processes and other things to help with implementation. And of course, how you measure things as well. I'll come on to that in a second. So they're our aims. How do we do that? In the olden days, we'd be coming to you. So we'd be coming to Essex, London, we'd be coming to Devon. Obviously now it's all virtual, but this is your site visit, which is your opportunity to hear from me, from us, but also our opportunity to hear from you. We'll be in touch by email. CQUIN isn't here today, or Brad will be in touch with you by email. Leah and Caroline, but Leah's mainly leading on them, organises smaller kind of clinics where it's not just you guys are invited, it's the whole country, and there'll be a topic for each kind of clinic. We've had ones on, we're going to have ones on safety plans. We've had others on various things, primary care, patient and public involvement, where we take an issue, discuss it in detail, and Leah has guest speakers, and they've been really popular. So I think Leah can put the registration details in the chat. There'll be a website, but the important thing is about shared learning. So actually it's about different sites of learning from each other, stealing ideas. In this context, stealing is really helpful. The website's there. We'll make all these slides available to you. The links are there, and this is in constant evolution. So you can go on the website. It's got various kind of, if you like, headings. Click on those. It will give you, for example, the latest information on risk assessment scales, what we know about self-harm in primary care. That's well worth a look at, and it's a live document. So please email us back if there's stuff missing, if there's stuff that's wrong, if there's stuff that you'd like to see there, because that's a resource for everyone. Measurement's really important. That comes up, again and again when we're talking to colleagues. How do we, if we're changing self-harm services, how do we measure if what we're doing is effective? Obviously, you can measure rates of hospital presentations of self-harm, rates of admissions for self-harm, and those data are often collected locally. Caroline's the expert on this, and we can pick it up with her in the chat. But actually, self-harm's really difficult sometimes to record because it's defined in different ways. On hospital systems, it can be coded. It can be coded as injury, it can be coded as distress. It's pretty difficult to get high quality data on self-harm, but worth doing. So there's some suggestions there from how you might do them. But also, if you think about how you evaluate stuff, there's things like process measures. So asking service users what they think, thinking about what the uptake of services are. And also, we know what markers of good quality services are like from the quality standards, measuring your own service against those. And there's a self-harm kind of toolkit available on the confidential inquiry website that we can kind of point you towards as well. So the data, I think, is really is important. Measurement is important. Now that's going to probably seem quite daunting. You're probably thinking, well, hang on, we're doing all these other things. How are we going to develop a plan for people who self-harm? I mean, you've got lots of things to kind of help you in a way. So you guys are in the second wave of sites. So last year, we worked with 10 to 12 sites who were the early implementer sites for the community transformation. And they did a lot of this. They did a lot of the thinking. They developed plans, which we then kind of commented on. And some of those are kind of summarized on the website. So Frimley, they were looking at interventions after self-harm, which I know is of interest to some of you on the call today, improving access, offering brief psychological interventions, and thinking about how they're going to measure impact as well. So that was around psychological interventions. Colleagues in Somerset, in common with a lot of areas, we're thinking about their digital offer. So what does a digital offer look like? And it's not just information, but also kind of resources, also kind of stories of hope, and again thinking about measurements. So I encourage you to look at that, look at the plans the early implementer sites have done, because I think that will help you. The other things that will help you develop your plans for self-harm is undoubtedly, there'll be lots of activities going on in your areas, and part of, if you like, this program of work is just bringing that together, is just harnessing it, knowing what's going on. Because often what we've done is we've gone to areas and they've said, oh, we don't have a plan for self-harm, and we said, well, hang on, no, tell us what you're doing. And when they tell us what you're doing, it's amazing the amount of kind of activity going on in this space. And actually they do have a plan, it's just not written down. So harnessing what's going on in the areas is really important, and there will be lots going on in your areas. But linking with other initiatives. So this is a CQUIN for self-harm that's come in this year. CQUINs are targets, if you like, for the NHS. They attract an additional payment, so they're incentives in some ways. And we're really pleased. After years and years of trying, we've got a CQUIN for self-harm this year. This is primarily focused on mental health liaison psychiatry services. So some of you, might be linked in with this, some of you might not. And it's really the idea behind it is to improve the assessment that people get if they present to hospital. So it's not community services, it's hospital services, but in some areas, it's the same people involved both in the CQUIN and the community self-harm work. In other areas, it's about linking in with the person locally who's responsible for the CQUIN for self-harm. So be aware, somewhere in your local area, there will be someone working on the CQUIN for self-harm, and we encourage you to link for that. Again, there's a kind of sister program to this one, which is a suicide prevention program, which has been going for 4 years, now has coverage across the country. Similar thing, funded by NHS England, where, if you like, the academic support, and again, 3 priority areas: mental health patients, people in midlife and primary care. But one of the priority areas there is self-harm. So actually within the suicide prevention program, they should have some self-harm work going on. Again, for some of you, it's the same people, so I don't need to tell you that this work's going on because you're responsible for that as well as this, but linking in again with that work going on for the CQUIN, going on in suicide prevention. Okay, so that's developing your plans. There's lots of activity that will be going on in your areas right now that you can link into. Just a couple of things on kind of overarching principles. Many areas are already doing this. I mean, patient public involvement is crucial in all of health. It's crucial in all of health research, but arguably it's even more important in mental health research, mental health service development. And I'd say it's crucial when we're thinking about services for self-harm. So yeah, making sure you involve local service users and carers in any plans that you develop. And there are recordings available of the initial events where we're launching this program. And actually, the power of the service user voice there really comes out. So we had Dr. M presenting there, and really powerful advocates for why things need to change, but also suggestions for how they change. So I think that is a really important overarching principle. Okay, so I've talked to you a little bit about the context, so hopefully you know where this program sits in. I've talked to you a little bit about the content of the current program. Just want to talk about different settings, because often when we think about self-harm, we think about emergency department settings or hospital settings, but this is, if you like, across the spectrum of suicidal behaviour, across the spectrum for self-harm. So many of you will have seen me present this before. This is the Iceberg Model of suicidal behaviour. So this idea that suicide and self-harm are like an iceberg with suicide at the top. Then you've got self-harm presenting to services, but then you've got all this self-harm that sometimes perhaps doesn't come to the attention of anyone that's, if you like, under the waterline. And this program is really about thinking what we provide at all points of the iceberg. So, thinking about people who are on community mental health service team caseloads, but maybe don't have access to psychological interventions. That's not a big part of the offer in some mental health services. Other people who present in crisis, but actually, services might say, well, there's no pressing severe mental illness need, so that we have to kind of pass them back to primary care. So thinking in this space about what we might provide for those people who just present to primary care, again, thinking about what might be the offer there, and also people who don't come to the attention of services, perhaps the most challenging group of all. So thinking about what we might provide across the whole spectrum, but also thinking about what we provide in different groups. So different groups, people who might have particular needs, so young adults. I've talked about older adults, some of the challenges there, but also groups that are sometimes excluded from traditional services. So Black and minority ethnic groups we know are less likely to access services after self-harm, people from LGBTQ plus communities who might be at higher risk of self-harm, and again, services might not meet their needs. So thinking across the spectrum, but also thinking about specific needs of specific groups. Just want to talk a little bit about ethnicity and self-harm. This is something we're asked about a lot. Overall, rates of self-harm probably are no higher in many ethnic minority groups than in white people. That is data from hospital presentations, though. So that might be more about help seeking than, if you like, base rates of behaviour. So, sometimes there's this thing around about, well, women from South Asian backgrounds have higher rates. But the evidence is at the moment they probably don't. But there's lots of difficulties with that research, collapsing ethnic minority categories, poor data, etc. But this is a study we did last year, which I think Busha Farouk, my colleague, led this. Caroline, who's also on the call, was involved. This is data just from Manchester, Derby, and Oxford, and looking at young people from ethnic minority groups who present to hospital following self-harm. And we know that they generally lived in more deprived areas than their white counterparts. But the big thing was about access. So everyone's supposed to get a proper assessment after self-harm, but young people from ethnic minority groups who self-harmed were less likely to be assessed and less likely to get access to follow up to mental health care. So there's a real kind of question there about equity, about access, and different areas. It depends on the catchment populations of your areas. In some areas, this is the most important issue that they're grappling with. In other areas, it's an important but perhaps not the central issue. But really important that you consider all the groups in your catchment populations. Thinking about settings, I mean, for me, this is about one of the most important settings and one of the most neglected, which is primary care. Thinking about self-harm in primary care, again, this is some data from a study we did a little while back, led by my colleague, Matthew Carr. And what this shows is it shows the proportion, the numbers of people presenting for self-harm in general practice as a national study, big national study, according to the deprivation of the area in which they live. So area 5, these are the most deprived areas, the people living in the most deprived areas. So unsurprisingly, like a lot of mental health, people who live in the most deprived areas were most likely to present with self-harm. So it's an important message, maybe not a surprising message, but a really important message. What's really tricky, though, is access to services for that group. So they're most likely to present, but if you look at the percentage referred to mental health services, that follows an inverse pattern. So they're the most likely to present, but the least likely to be referred. So an example of the, in public health, we call it the inverse care law. People most at need, least likely to get referred. So that's something certainly to be thinking about in terms of access, in terms of the wider determinants. In terms of the evidence, though, it's a real opportunity, I think, because there isn't a lot in place in general practice. Obviously, it's very challenging. Just yesterday in the news, thinking about some of the challenges in primary care, we're asking our general practice colleagues to do a bit of everything. Self-harm, is that another thing? It's a key part of what I think lots of specialists and non-specialists are doing. This is a review by our colleague Faraz Mughal, works in Kiel, worth having a look at. Thinking about some of the things which facilitate self-harm care in general practice, some of the barriers. Barriers will be familiar with, referral thresholds, systemic factors, not having the services to refer to. Facilitators, so how you can make things better. Training comes up a lot. We can talk a bit about that. Thinking about how you adopt clinical guidelines involving young people as their families. So there's things you can do to improve things in general practice. Obviously, some barriers. Have a quick look at Faraz's review for further information. So primary care, a crucial setting. But the other setting, I think, especially if we're talking about community settings, are educational settings. So often young people will present. Now, this program, the Community Self-Harm, the Community Transformation Project, is focused on adults, but obviously within adults, there are younger adults and older adults. So thinking about universities is really important. But actually, this will dovetail again with the work that's going on in relation to kids and mental health in your areas. So do have a think about that. Some areas, the university angle is more important than others. Very, very big student populations. Of course, the other crucial area is home, and thinking about what you might offer for parents, for families, for carers in terms of improving the offer. And our third sector colleagues have a crucial role to play as well. This is Harmless, one of the biggest self-harm charities. This is Samaritans, which will be very familiar to you. Locally, we've got Samaritans helping to provide a follow-up service for people who aren't assessed in emergency departments, really, really helpful doing that in a few areas. Harmless are actually directly involved in service provision in Nottingham and in other areas. So the third sector, involving the third sector in your plans, in your service developments is really important. Okay, so I've talked a little bit about the context, I've talked about current programme, different settings, so primary care, education and home, and then remember across the spectrum. Let's talk a little bit about the evidence. So often you'll hear, when we're talking about self-harm, we're talking about suicide prevention, oh, well, we don't have the evidence. Well, the evidence is patchy in some ways, but we are quite lucky in that I think there is evidence out there. And the other thing that we've got is we've got the nice guidelines on self-harm. So there's one in 2004, 2011, and we're redoing the nice guideline at the moment. Some of you kind enough to have commented on the draft guidelines, and we're expecting to publish that over the summer. Also got quality standards, which are in some senses summaries of the self-harm guidelines. So the guidelines themselves, based on evidence, based on expert consensus, and they can help us in terms of the evidence for what works. Training is the other thing that comes up again and again and again. Well, what about training? What package should be used? We don't tend to recommend individual packages. There are lots of packages out there. Some of them are provided on a commercial basis, which I think makes things slightly kind of trickier if your organisation's paying for them. But we did do this bit of work 2 or 3 years ago, which is a competence framework. So we developed, along with colleagues at Health Education England and the National Collaborating Centre, this competence framework. It's the knowledge, skills and attitudes we'd expect staff to have when they're dealing with people who have self-harm. There's one for adults and older adults, there's one for kids, and there's one for people working in non-specialist settings. So you can click on these, it gives you an indication of the skills we'd expect staff to have. And what we've encouraged areas to do is either audit the training they're already provided against this. Are there gaps in the training? What could we do better? Or some people are developing bespoke training, base some of the training around these competence frameworks. So encourage you to have a look at that. Encourage you, of course, to have a look at the guidelines. There's guidelines out there, there's competence frameworks. Just in terms of the evidence, some of the most important evidence is, I think, the simplest. So what helps? One of the things that helps is if people present, and I think that's to any part of the service, the data are from emergency departments, but for any part of the service, just making sure they're seen. So making sure they get a proper assessment of the antecedents, what's going on for them, their psychological health, the psychosocial assessment. Why is that important? I mean, it's a responsibility that we assess people after they self-harm, of course, but there's also evidence that it might reduce the risk of self-harm by 40%. Just doing the assessment might reduce the risk. How does it do it? If we're just assessing people, how does that reduce the risk of repetition by 40%? So this is a lovely paper by Leah, who's on the call. I encourage you to have a little look at it, where she's actually asked kind of patients, she's asked carers, what actually helps, and things you'd expect, care that's humanising, assessments that are collaborative, having space and time to talk, a clinician or person that treats you with compassion and reassurance. So there's things there about what happens between the clinician, between the practitioner and the service user, feeling heard, feeling listened to. But there's also what happens after the assessment, so receiving help. So you do the assessment and then you plug people into the help they need, and that will help. So in terms of one of the simple things we can do is to make sure, across our patch, across our services, people are getting assessed. But also that they then have access to aftercare that's been shown to be effective. So talking treatments are effective. How do we know that? I won't bore you with the complicated slide, but here you go. This is a forest plot. This is lots of different research studies looking at interventions after self-harm. And the bottom line is this, that if people get a talking treatment after self-harm, they're about 34% less likely to repeat. People ask what kind of treatments are these? In the Cochrane review in this study, they call them CBT-based therapies, but actually it's a wide variety of different things: psychodynamic interpersonal therapy, problem-solving therapy, conventional CBT, but some kind of psychological intervention, providing some kind of psychological intervention is really helpful. And some of the areas have developed services in that space. The important thing to say, though, is it doesn't matter what kind of type of interventions you provide, you know, if you do problem solving, interpersonal therapy, the important thing is to get in there quickly. So timely intervention is really important. Why am I saying that? This is data from the MASH project, self-harm project, which Caroline helps run. We're looking at people repeating self-harm and how quickly they repeat. And basically, over 30% of people who are going to repeat within a year do so within the first month. And actually, 1 in 10 people who are going to repeat within a year do so within the first 5 days. So if we want to intervene, we have to get in there quickly. So if we're setting up interventions, they need to be timely interventions. Otherwise, we're kind of wasting our time. And psychological interventions, the importance of assessments. Many areas are using safety plans. So it's this idea that, you know, the clinician might sit with the service user, think about warning signs, coping strategies, making contingencies. Well, if I feel like this again, what am I going to do? There's online versions, pencil and paper versions, lots of versions around. And, you know, are they a good idea? Well, personally, I think they're a good idea. The research evidence, though, is kind of surprisingly kind of mixed. So there's a couple of systematic reviews which both conclude, well, there's something in these, the safety plans can work, but it's not by any means clear-cut. There are very few randomized trials. There's one coming, but there's very few randomized trials. You know, the evidence isn't clear-cut, but do I think they're a good idea? I think they are, and many areas are doing them. But it's about one of these. It's one of these things that's quite common, which is the how is just as important as the what. So it's not about the individual categories or anything. It's about how staff are using them and how, you know, in this review in particular, it talked about, you know, what service users experience is helpful. So making sure they're accessible. So they're accessible either on a clinical record system or to the service user themselves. Make sure they're personalised so it doesn't turn into yet another tick box exercise. Make sure they involve family members and others, and make sure they're kind of truly collaborative. So those are the things that people experience as helpful. And there's various kind of guides out there that I'd encourage you to look at. There's no kind of definitive guidance, but you know, this is the original stuff from the US. This is stuff here from Oxford. There's also Cornwall and the Isles of Scilly, you know, as in phase 1 of this program have done a little bit of work around safety planning. So safety planning, yeah, big thing, a lot of areas doing it, very prominent at the moment. The evidence isn't great, but thinking about, you know, if you are doing safety plan, how you're doing it and how you're evaluating that. Safety plans are an area that receive lots of attention, but digital interventions are another. So, you know, we've all, over the past 2.5 years, certainly been thinking a lot about digital. What about digital interventions in self-harm and suicidal ideation? Well, this is interesting because it's 2 groups of researchers who have essentially done systematic reviews of the same thing, but reached slightly different conclusions. So Helen Christensen and colleagues in Australia, they're really enthusiastic. You've got to promote use of these. These colleagues are a little bit guarded, saying further research is needed. I think my own view is yes, they definitely show promise. I think we do need to be a little bit cautious about a wholesale adoption of digital kind of interventions. I think for me, it's about choice. So for some people, actually, they prefer online interventions, but providing that choice is crucial. And yes, we do need to evaluate how digital interventions kind of pan out. But yes, they're a promise, but no, they're not a kind of panacea. So safety plans, digital interventions. Here's something I think is less helpful: risk tools and scales. So again, this is mostly Leah's work. You know, in every mental health service in every country, they're practically ubiquitous. You know, you rate people on a risk of suicide scale, or you give them a score, or you rate them as high, moderate, or low, or a traffic light system. In fact, the evidence is they're not very good. The positive predictive value is 5%. What does that mean? That means if I rate 100 people at high risk, only 5 are at high risk. In other words, they're wrong 95% of the time. But that isn't even the big problem. It isn't the problem that you're rating people at high risk that they're not to be. It's because there's lots and lots of people rated as at low and moderate risk and excluded from care. You miss people who sadly go on to die by suicide. So the problem with the risk tools and scales whole kind of thing is the exclusion, missing people. And this idea that you can reliably predict or reliably identify is a nonsense. So the idea is not to use those and to think about, you know, what you do instead. And there's lots of suggestions on our website, but it is partly about better care for every single person that comes through the door, because actually you can't identify that, you know, 1 in 100 person who presents with self-harm that's going to die by suicide and during the next year, because that's the rate, you know, it's about 1 in 100 after presentation for self-harm. It's impossible to identify that one person because lots of people have the so-called risk factors. So it's providing better care for all of the 100. Okay, the last thing I want to cover just in 2 or 3 minutes is self-harm and COVID-19. It's really hard, you know, I find myself kind of thinking back to what it was like in April 2020 and, you know, all the things we were worried about. And, you know, we were really worried about the effect on suicide, on mental health, on self-harm. And early on, we were getting signals that, you know, the pandemic was having an adverse effect on mental health. So this is looking at mental distress before and after or during the early stages of the pandemic. So no doubt it had effects on mental health. But the effects, I think, on self-harm have been much less clear-cut. A lot of the data has been from presentations for healthcare settings. So early on, we talked about, you know, what was happening in emergency department and primary care settings. This is data, massive study led by Sarah Steve, Matthew Carr on self-harm primary care in primary care. So it's primary care, what happened to presentations? The yellow line is what was happening before in a previous year. The purple line is what happened during the early stage of the pandemic. And basically the big thing was people stopped coming into healthcare. That was obviously part of a wider trend. People were worried. People were told to protect the NHS, but also, you know, thinking about access to services for mental health, services for people who self-harm, perhaps less available at that point. It's also a suggestion looking at suicide. Suicide rates actually dropped early on in the pandemic. So it's possible self-harm rates dropped through. But the big news really was this lack of access for people in crisis. Thinking about things kind of slightly longer term, this goes up to May of 2021 now. Again, the big thing was, you know, lack of help seeking early on, which kind of rebounded. But just look at this graph, and something concerning about this graph, and it's people in age 10 to 17, presentations for self-harm in primary care. You know, young people, the rates may well have gone up, and that's a part of a kind of worrying signal about the mental health effects, the effect on suicidal behaviour in young people. I think young people are, you know, are a group who we have to watch. That's what happened in healthcare settings, fall early on, possible rise in young people. What was happening in the community? Lots of people don't present. We don't have data before, but during we've got very good data from the UCL study. And it's been fairly flat levels of self-harm in the community, actually. But this is a reminder that for people with a mental health diagnosis, rates are always higher. So for people with mental health diagnosis, they're more at risk of self-harm. But not a lot happening in terms of changes over time. It's been you know, fairly constant. So people didn't seek healthcare at parts of the pandemic. The rates, if you like, in the community were stable. So the question is where the people were going for help. And this is one possibility, it's helplines. So this is a study not based on UK data, but it's a call to telephone helplines, mostly kind of suicide telephone helplines, and showed an increase. So people were going to the third sector, they were going to helplines. Interestingly, though, a lot of these concerns weren't about suicidal thoughts, or about worries about the pandemic, worries around kind of finances. So not necessarily directly related to mental health, not directly related to suicidal behaviour, but again, an illustration of the importance of involving the third sector. Just in the last couple of minutes, then, changes to management. So, it's a bit unclear what happened to self-harm, but one of the things we know for certain is management changed. So this is a study where we looked at management, how people with self-harm were managed in primary care before and after the pandemic. And the line of one says, basically, if a bar hits the line of one, it's the same before and after. Basically, one of the things we know is during the early stages, first 5 months of the pandemic, many more people were consulting remotely than were consulting face-to-face. But actually, the other thing is referral to mental health services went down, and that's important. So not only did the presentations for self-harm reduce in that first phase, and at times subsequently, but people were less likely to present. But then even when they presented, they were less likely to be referred. So this idea of a gap in care, I think, is really important. But actually, there was no evidence of this, digital exclusion here. So people in the lowest socioeconomic groups were just as likely to consult remotely as people in the higher groups. But this a bit of concern in younger people, because they were more likely to prescribe medication after self-harm during the early stages. So some interesting changes to management there. But obviously, the big things that's coming up is maybe partly as a result of the pandemic, but wider pressures now. And this is going to have a big impact on mental health. Sadly, it's going to have an impact, I think, on suicide and self-harm as well, which is going to be the economic fallout and what we can do to try and mitigate that through services. There's a limit to that, but there are things we can do. So I've told you a little bit about the context and the current programme where that fits in. Thinking about what you offer in each of your different settings, the evidence around assessment, around interventions, safety plans, digital interventions, all those things are a good idea. Risk assessment probably isn't a fantastic idea. So we'd be saying, not, to kind of think about alternatives of that, and a little bit about self-harm and COVID-19. But the big story there, I think, is what's to come in terms of economic impacts. And just I like to show this slide last of all, just our staff, all of whom are involved. So this is a collaboration between Confidential Inquiry, Manchester Self-Harm Project, and the Patient Safety Centre. So we've got colleagues from all three places on the call. So at that point, I will stop